Greetings, everyone. I am Naya Fowler. This is my presentation on diabetes in elderly Black non-Hispanic women compared to diabetes in white non-Hispanic women, focusing specifically on rural and urban communities within the state of Alabama. Diabetes is one of the most pressing chronic diseases in Alabama, affecting over 500,000 adults statewide. Is also a lead contributor to health disparities, especially for Black women. Diabetes is the seventh leading cause of death within Alabama within the past year, and over 25% of adults ages 65 and older have diabetes, but the rates are higher within Black women specifically. Diabetes is a huge contributor when it comes to the morbidity rate and healthcare costs. My objectives within this presentation is to examine diabetes patterns using descriptive epidemiology, compare outcomes between Black and white women in Alabama, and also explore rural versus urban differences within the communities. So, who's affected? When we look at a person's level characteristics, age and race both stand out. Elderly women, especially those over 65, experience higher diabetes prevalences and complications compared to younger age groups. Race also does add another layer because according to Office of Minority Health, Black women are twice as likely to be diagnosed with diabetes compared to a white woman. In Alabama, this disparity is even more pronounced. And this matters because diabetes risk is influenced by both biology and social determinants. Elderly Black women often face the barriers in preventions, screenings, and treatment access. Social economic statuses also play a major role. In Alabama, poverty rates are higher among elderly Black women, especially in rural areas, and poverty is linked to the limited access of healthy foods, healthcare, and simple diabetes education. There are a few gaps in the literature, though, and in data regarding occupation, religious affiliation, marital status. There are not extensive reports on this specific part of the data, but when gathered, it does give further insight. Place is a critical factor. Alabama has some of the highest diabetes prevalence rates in the country, but rural counties definitely get hit the hardest. For example, Perry and Marengo, Alabama, have the highest rates at about greater than 38%. But then you also have urban counties like Birmingham, Alabama, or Montgomery, Alabama, who has better access to clinics and show lower prevalence. But this disparity, it still persists in low-income neighborhoods around the cities. Neighborhoods and county level factors like by proximity to a grocery store or hospitals further define who is most at risk. This bar graph illustrates diabetes prevalence in Alabama, broken down by race, location, and age group. What immediately stands out is the difference between Black elderly women and white elderly women and between rural and urban communities. Among Black elderly women in rural Alabama, prevalence can exceed 35%. That means more than 1 in 3 women over the age of 65 is living with diabetes in some counties. This represents not only a personal health challenge, but also a major burden on families and local healthcare systems. In contrast, white elderly women in urban areas average closer to 22%. While that number is still high, which is more than 1 in 5 women, it is significantly lower than what we see in rural Black population. This gap highlights how both race and place combine to shape health risk. The urban-rural divide also matters. In urban settings, even when prevalence is high, there is typically a better access to diabetes educators, pharmacists, and hospitals. Rural communities often lack these resources, making it harder to manage blood sugar, obtain medications, and prevent complications. And in short, this graph makes the disparities visible. Diabetes is widespread across Alabama, but elderly black women in rural areas are carrying the heaviest burden, while elderly white women in urban areas experience lower but still significant rates. This visual helps us see the impact of structural inequities layers on top of biological risk. There are a multitude of challenges that come to mind when we speak about diabetes in rural communities, and number one being access to health care. Limited healthcare access is one of the biggest challenges in rural Alabama because there are probably individuals who have to travel far distances just to get basic diabetic care or even education. Obesity and inactivity is another one, which are common for places that lack safe parks, sidewalks, or even healthy food options. Rural communities may lack grocery stores with fresh products, leading to reliance on processed food. And transportation may also become a barrier when needing to travel to appointments. Whereas urban environments, on the other hand, may have more resources, but food deserts and unsafe neighborhoods can still limit access to healthy choices and physical activity in both settings, which increases this burden. When we speak about these chronic diseases, there are always underlying risks, and comorbidities are widespread, such as high rates of obesity, hypertension, and high cholesterol, especially among elderly black women, amplify diabetes risk. But so does genetics play a hand as well, because black women have an increased genetic predisposition for diabetes and related complications. And lastly, another factor would be unequal health behaviors, such as screenings and preventative assessments are much less frequent in rural settings. Underserved communities are diagnosed later and suffer more complications. These biological vulnerabilities intersect with social environment barriers, amplify this specific disparity. As we look at social environments, community and family support can decrease diabetes risk. But in Alabama's rural black communities, both poverty and historic inequities have weakened these supports. Educational resources, especially for chronic disease management, are fewer in high risk counties. This directly impacts what people know and do about their health. Statewide policies like limited Medicaid expansions further restrict access to affordable diabetes care. In rural Alabama, faith-based organizations sometimes serve as key sources of health education and outreach. However, the mistrust of healthcare providers can create barriers, whereas in areas, stronger access to community programs may exist, but that's not to say that they are equally distributed. As we continue to look through the times and patterns, from 2016 through today, diabetes rates among the elderly in Alabama have steadily risen. In fact, reports from the Alabama Department of Public Health shows that the state continues to rank among the highest in the nation for diabetes prevalence. Unlike seasonal diseases, diabetes is a constant challenge every day, week, and month of the year. While conditions like flu or allergies come and go in cycles, diabetes require continuous management. That means consistent access to medications, glucose monitoring, and even lifestyle support. For elderly women, especially those with limited income or transportation, that daily burden can create significant health gaps compared to those with higher income and more accessible resources. In conclusion, elderly black women in rural Alabama faces the highest burden of diabetes. This disparity reflects overlapping effects of age, race, environment, and social and economical status. Descriptive epidemiology not only reveals these critical differences, but also highlights where targeted interventions are most needed. Addressing these issues require more than clinical care alone. It requires targeted policies to reduce food insecurity, expand rural health care infrastructure, and strengthen culturally tailored education programs that resonates with Black women and their communities. If we do not address these root causes, the burden of diabetes will continue to fall most heavily on those with the fewest resources to be able to manage it. I based this presentation on reports from the Alabama Department of Public Health and Office of Minority Health and other sources listed here. Thank you so much for watching my presentation. I hope you all have a great day.